presentation. Thanks for being here.
Sure. My name is Linda Peterson. I'm a professor of medicine in cardiology at Washington University. I have a joint appointment in radiology. I've been at WashU for a long time. Not quite a lifer. I did go elsewhere for college, but I've been at WashU since medical school and did my residency and cardiology training at WashU as well. I'm the medical director of cardiac rehab at WashU and for VO2 peak testing that we do for a lot of heart failure patients and for congenital heart disease patients. And Jose had asked me to discuss this journal article, and it's reduced cardiorespiratory fitness and increased cardiovascular mortality that is associated after prolonged androgen deprivation therapy, which we'll be calling ADT, for prostate cancer. And these are the different authors. And let's see, how do I advance the slides here? It's not letting me page down. How do I page down? Steve, do you know how am I?
Yeah, I don't have control over your screen. You should.
And my usual thing is to page down. I have a Mac.
Yeah, I wonder if there's a.
It'd be a very short talk. No, sorry.
Yeah, right.
Hey, Linda, you should be able to press the arrow button to the right on a Mac too if the page down's not working.
Try the arrow button to the right.
Yeah, I'm hitting that and it's not letting me do that.
And the mouse button's not working either.
There we go. Okay.
There you go.
It's the mouse button. Thank you. I have no disclosures related to this journal club discussion. Disclosures generally related to cardiology are there. So just to give a background about both cardiovascular disease and prostate cancer, which I know this group is well aware of, but basically cancer overall and cardiovascular disease, heart disease are, number one and number two causes of death. And cancer causes of death are actually, very high. Prostate cancer obviously only affects men, and the death rate is only 9%. So it's not as high as this overall cancer death amounts. So basically the question is that prolonged androgen deprivation therapy, or ADT, is favored over short-term use in patients with localized high-risk prostate cancer. CVD is the leading cause of death in men with prostate cancer, though. So it's more men are going to die of CVD than of the cancer itself. ADT regimens of higher intensity and duration are being increasingly used in clinical practice because they have better prostate cancer outcomes. But study results, there's controversy, which I remember Victor Davila always telling me, controversy is your friend, because then you have something to research, right? If everything's known, then you don't have anything to say in a new paper. So study results have been equivocal, some showing an association between ADT and cardiovascular disease, and some not showing a correlation between the two. These previous studies have used normal controls rather than patients with prostate cancer who didn't receive ADT. So there's a bit of a difference between those previous studies and the current study we'll look at. And the previous studies didn't evaluate short-term versus long-term. And for the purposes of this talk and this paper, short-term is defined as less than or equal to 6 months. So cardiorespiratory fitness is a strong predictor of all-cause and cardiovascular mortality in whatever group you want to look at. And I'm showing VO2 max testing over on the right. None of our patients are ever running on the treadmill like that. That's a VO2 max test where we're actually gathering expired air and analyzing oxygen consumption. But nevertheless, either when you test for VO2, or measure cardiorespiratory fitness either by VO2 testing or by METs on an exercise treadmill, the better you do, the better you do. So the better you do on the test, the more likely you are to live longer. And this is just one of our previous papers looking at heart failure patients who obviously have really low oxygen consumption, heart failure with reduced ejection fraction patients. And just if you dichotomize to those above 14 milliliters per kilogram of oxygen per minute versus those less than or equal to 14, they definitely do worse. And this is in patients who are not on beta blocker therapy. And for each VO2, for each milliliter per kilogram per minute, improvement is associated with about a 5% increase in survival. So you think, oh, it's just a 1 milliliter per kilogram per minute difference. It still has an impact on survival. And that same thing extends for exercise treadmill testing with METs. So the association between the ADT exposure and length of exposure and cardiovascular fitness was controversial. So that's why we were doing this. They were doing this study. So the objectives were to look at cardiorespiratory fitness and cardiovascular death in a large cohort of patients with prostate cancer, those with and without ADT exposure. So that was the first question that they wanted to ask. And the second question was to explore the influence of long-term versus short-term ADT usage on both of these endpoints. So for methods, and I had to review Gleason's scoring for myself because that's not something that I'm looking at all the time. I have a picture of Gleason's pattern scoring over on the right of my screen so that you can see sort of the progression of the histological changes that correspond with the increasing severity of the prostate cancer. This is a retrospective cohort of patients who referred to the exercise treadmill testing after they had a diagnosis of prostate cancer. So they had to get referred for a clinical reason. This wasn't a prospective look at patients with prostate cancer who then were randomized to getting exercise treadmill testing. This is a retrospective look. The final cohort looked at 616 patients, so it's a large study, who had undergone treadmill testing between 2002 and 2015. The demographics, they had the indication for the exercise treadmill. They had medical history and medications. A lot of that detail wasn't rigorously looked at in their multivariable analysis, but we'll get to that in a bit. And then, as I said, they looked at the oncology history, the Gleason score, and the ADT treatment. So this is their consort diagram. So they basically looked at 28,000 patients that were referred for exercise treadmill testing. And then of those, 1,200 had the ICD code for prostate cancer. So they looked at through medical EMR review, and then several were excluded because they couldn't confirm that. And you can kind of go on down the tree here to see that their final cohort was 616 patients that were referred for exercise treadmill testing. And the average time since their diagnosis of prostate cancer was 4.8 years. So they did a symptom-limited exercise treadmill test according to standard Bruce protocol. Again, this is different than what we do in the VO2 max lab because most of our patients can't even finish stage 1 of the standard Bruce protocol, or certainly not stage 2. So this is more of a standard Bruce protocol. They had heart rate and blood pressure recorded, and cardiorespiratory fitness was expressed in METs, which we all know, but I thought it was helpful to look at the MET equivalent in terms of activities of daily living and what they were classifying as good cardiorespiratory fitness. And I kind of hate that they had CRF. I always think of cardiac risk factors for CRF, but for here it's cardiovascular fitness, and they looked at less than or equal to 8 as being reduced, or greater than 8. But greater than 8, when you look at that, is a basketball game. I mean, those people are pretty fit, swimming moderately hard, which I used to do, but as a swimmer, but now I don't anymore. Now I'm more down in here because with my morning workout on the elliptical in the basement, I kind of watch a movie and at least do something, but I don't think I'm up here in the 8 range. So just to give people a reminder, for over 8 is pretty vigorous exercise performance. So looking at the baseline demographics, as we said, the first look that they wanted to do was ADT treatment versus non-ADT treatment controls. And the only real difference between the two groups was the body mass index was slightly higher in the patients on ADT. So it was good that, otherwise there were not huge statistical differences between the groups. The patients on non-ADT trended towards having more cardiovascular risk factors. And then when we looked at the, and I can't see the part of my screen here because the GoToWebinar control panel's over it, but if you look at the less than 6 months here versus the over 6 months, so that's their second aim of their exploratory aim of their study, there were differences in the interval from the prostate cancer diagnosis to the treadmill test in years. So the people that had ADT for more than 6 months typically were farther out from their prostate cancer initial diagnosis. Looking at the oncology characteristics of the study cohort, there were a lot of differences between the ADT and non-ADT group, which probably informed whether they got the ADT. Nodal diagnosis at the time was higher in the group that received ADT, but it was interesting to me, so nodal diagnosis was higher in that group, but metastatic status at the time of initial treatment was higher in the non-ADT group. Prostate cancer was thought to be high risk in the ADT group, and prostatectomy was higher rate in those with non-ADT therapy. But all along there were several differences in terms of the oncology characteristics. Again, there were a lot of differences also between the ADT less than 6 months versus more than 6 months. Nodal positivity was higher in the ADT over 6 months. Metastatic was higher in the ADT over 6 months. High-risk prostate cancer grouping was higher in the over 6 months, and the prostatectomy as an initial therapy was higher in that group. So there were several differences, no matter which two groups they're comparing here, either for their first aim or their second aim. And just looking at external radiation, any chemotherapy, recurrence or progression, biochemical recurrence, there were differences in the no ADT versus the ADT group, as well as between the group that was less than 6 months versus over 6 months. And I just highlighted the p-value. So there were several differences in terms of oncology status, both in the first aim comparison groups and in the second aim comparison groups. Looking at the differences, though, in the exercise treadmill testing, or ETT, indications and results, there were definite differences between the ADT group and the non-ADT group when you look at the cardiovascular performance. The people in the non-ADT group did better, which is part of the aim of the study, compared to the non-ADT group. The METs completed at peak were higher in the non-ADT group. Classifying things in a dichotomous way, either over 8 or under or equal to 8, was a higher percentage in the over 8 group in the non-ADT group. And conversely then, in the reduced group, there was a higher percentage in the ADT treatment group. So this is kind of first pass raw data look at and simple comparisons between the ADT and non-ADT group. But when looking at just the raw comparisons, and obviously the numbers are going to be much smaller here because you're only taking this 150 people that got ADT and dividing them up now into less than 6 months or over 6 months. There's going to be a decrease in ability to detect a difference, if there is one, because of sheer numbers compared to this comparison. But that said, there really weren't statistically significant p-value differences between the groups. If they looked here at the p-value is 0.08 and looking at the exercise duration, again, the ADT group that's higher had longer duration of therapy, went less far on, paradoxically, went less far on the treadmill, but it did not reach statistical significance. So in looking at the associations of ADT treatment of any duration, and then short-term use and prolonged use with cardiorespiratory fitness and cardiovascular mortality here. So looking at odds ratios now, no ADT is going to be the baseline set at 1. If patients had any ADT, so that's all 150 patients, they had a higher odds ratio of having a reduced cardiorespiratory fitness. And those under 6 months or equal to 6 months ADT treatment, it was 1.7, so it was less, and it didn't quite meet statistical significance, but it was trending that way. Those over 6 months, it was definitely higher. So it appears, though, the longer that patients were on the ADT, the lower their cardiorespiratory fitness performance was. And looking at cardiovascular mortality over here on my screen, it's on the right, what they saw was that the odds ratio was much higher, 3.6 here, in the patients looking at unadjusted and then after adjusting here. So I was only really focusing on the adjusted cause-specific hazard ratios, was higher statistically in the group that had the ADT for over 6 months. Okay, so again, we're not going to, cardiovascular mortality didn't have adjusted hazard ratios that were statistically significant across the board. Those under 6 months or equal to 6 months, the p-value was not statistically significant. Again, now you're breaking the numbers down, so it's smaller, and you're going to have less power to detect a difference. I will say they only adjusted for age, prostate risk group, Maurice score, and body mass index. So they weren't adjusting for diabetes, smoking, a lot of standard cardiovascular risk factors, especially when you're looking at cardiovascular mortality. There weren't a lot of standard risk factors that were added into the modeling here, and which I think is a bit of a limitation. Frequency of reduced cardiorespiratory fitness in ADT exposed patients versus ADT naive patients. Again, just another way of showing this, that the ADT naive patients were less likely to have reduced cardiorespiratory fitness as defined as less than 8 METs achieved. And whereas almost half of the patients who were on ADT for any length of time couldn't make 8 METs. Looking at the cumulative incidence of cardiovascular mortality now, and looking at over years of follow-up. So one of the strengths of this study is that they did have, several years of follow-up. And looking at the no ADT group as the comparator, the less than or equal to 6 months is much closer to the ADT as opposed to the folks with ADT over 6 months. And this just is a different way of showing things over time that we saw in the odds ratio analysis earlier. So to summarize, we had a large study, or they had a large study. It was 616 patients that underwent exercise treadmill testing. They had a lot of follow-up, and the median time after prostate cancer diagnosis was 4.8 years. Of these 616, then, looking at the subset of 150 who got ADT of any time length, 24%, so that 24% received some sort of ADT. And if you divide those up, 99 of those had short-term exposure, whereas 51 had the prolonged exposure. And a lot of the patients had many cardiovascular risk factors because that's how they got referred, like, helped get them referred for exercise treadmill testing. And they saw that prolonged ADT was associated with reduced cardiorespiratory fitness and increased cardiovascular disease. It should say CVD mortality in the adjusted analysis, although those adjusted analyses were fairly limited in what they adjusted for. So although the association between short-term ADT and reduced cardiorespiratory fitness was borderline significant, there was no association with the cardiovascular mortality with the short-term ADT in the Cox regression models. And I should say, though, the long-term association was associated with both reduced cardiorespiratory fitness and higher cardiovascular mortality. So just some limitations and thoughts here is it's a retrospective study, so there's obviously referral bias. It was only studying people who got referred for an exercise treadmill test, so most people have to have some reason for that, either high cardiovascular risk factors, family history, et cetera, or chest pain or something. So they're going to be at higher cardiovascular disease risk to begin with and higher risk for CVD death than a priori. Multivariable analysis, as I said a couple of times, I thought was fairly limited for their confounders. They didn't look at, add in diabetes into the model, smoking into the model, lipids. There were several things that weren't looked at. There was not in-depth phenotyping of this study, retrospective study. So they didn't do DEXAs to look at muscle mass, which obviously affects exercise performance. They didn't look at cardiac function, either at rest or with exercise. LV mass, we know muscle mass is obviously affected by testosterone. Hematocrit's affected by testosterone. There was no measurement of hematocrit, which is going to be your oxygen carrying capacity, which is going to affect your cardiorespiratory fitness. They didn't do VO2 testing, which would be a little bit more in depth to look at oxygen consumption. They didn't look at lung function, which obviously is going to affect cardiorespiratory fitness and the ability to perform exercise with PFTs, O2 sat monitoring. So this was, a large study with a long follow-up. It had several, pluses to it, but it was fairly limited in terms of ability to look at the whys, or how did this happen, to explain why they found what they found. So they have, in this central illustration, as they called it, possible mechanisms, just, these are things we know are associated with testosterone, decreased muscle strength if you take away testosterone, decreased bone mineral density, although not sure how that changes your cardiorespiratory fitness, but decreased lean mass, obviously, increased percent body fat. They didn't mention decreased crit or O2 carrying capacity at all here, but they're just sort of throwing these out as possible mechanisms of why they saw reduced cardiorespiratory fitness and increased CVD mortality. And then they question about the exercise intervention, if that could be used to mitigate the cardiorespiratory fitness problems and the CVD mortality that was seen with the ADT therapy. So some conclusions among patients with prostate cancer and high baseline CVD risk, prolonged exposures was associated with reduced cardiorespiratory fitness and increased cardiovascular mortality. Reduced cardiorespiratory fitness may in part mediate the increased risk, because we know that low exercise performance is associated with increased risk. And so that might be a therapeutic target, and just throwing out more mitigating strategies than what they had put on their list, in addition to exercise training, particularly cardiac rehab. And I think it also speaks to not just exercise aerobic training, which we know increases VO2, but also muscle building, just building up muscle mass, which is likely decreased in patients who have ADT therapy. EPO plus iron, just throwing out things to increase oxygen carrying capacity. Inorganic nitrate is a study we're doing now, looking at patients with heart failure with reduced ejection fraction. It improves muscle performance. And we've shown in heart failure reduced ejection fraction patients that it's increasing exercise performance on the treadmill and improving muscle power. So we're in the midst of doing a we finished our phase 1A and 1B studies, and now we've just put in a grant for looking at a phase 2 clinical trial to look at inorganic nitrate in HFrEF patients. No reason that that might not be helpful as well in some of these patients. Other ways of improving performance, looking at the athletes, because they always do things first and they're willing to try anything to get their performance better. Ketone supplementation, there's multiple reasons why that might be helpful. And then the question for other cancers for me is, would testosterone therapy help in a targeted way, perhaps in people who have, not a bad lipid profile, et cetera, especially in older men who have low testosterone levels to begin with? Could that possibly improve their muscle mass, exercise performance, and if not their quantity of life, quality of life? Just trying to be provocative. And just looking at one other study here that was done in BMC Cancer recently, where they had patients who had head and neck or cervical cancer, and this was a randomized controlled trial. They randomized patients to getting IM testosterone versus placebo, and they showed improvements in stroke volume, ejection fraction, even diastolic function changed, and probably in part because this ventricular vascular coupling was improved. Arterial elastance was better. And I know that there are several downsides to testosterone, including lipids, et cetera. But like I said, perhaps in the right patient, this might be a possible therapy to test in future clinical trials. And with that, I'll kind of stop, and I've kind of been talking at everyone here and get everyone else's opinion on this.
Linda, Linda, this is Dan. Thanks so much for doing this.
Sure.
We appreciate your insight. The biggest issue with with this particular study, but also really, any study that we're looking at in prostate cancer, is that there seems to be this major disconnect in my mind. So, you looked at in detail this particular paper, and the only difference was found in people that were on ADT for a longer period of time. And then there were a couple of major studies reported this year at ASCO, the cancer meeting, that were looking at enzalutamide or drugs like that, which are, the androgen receptor blockers. And they showed that those drugs on top of ADT were beneficial. They were, in terms of overall mortality, they were helpful. And then when you look at those mortality curves, it's striking to me, because if you look up the cancer outcomes in prostate cancer, they would say the 5-year survival rate is greater than 99%. So they say men die of something else, and which is fascinating, because then when you look at the Prosper study, which was one of these major trials, the 5-year survival rate was around 50%. The 5-year overall survival rate was 50%. And the reason that they died was cardiovascular in nature, as best you can tell from the study. So you look at the American Cancer website, Cancer Society website, and people survive forever who have prostate cancer, but their actual survival is quite limited when you look at those people that are on ADT or other anti-androgen drugs, because something is changing in their metabolic picture that is making their cardiovascular disease worse. And so the actual overall survival is surprisingly low in that population. So I'm not sure, if that ever comes through when we start talking about prostate cancer, that the reason people are dying are cardiovascular disease, and their overall survival is not that great, especially when we give ADT or other anti-androgen drugs. And then to your last comments about testosterone, there's no way you could give that to a prostate cancer patient.
No,
since
of course.
since you're giving them an anti-testosterone. So
No, I know that. I said that for other cancers, I just being provocative in somebody who's cachectic, in a selected person who, potentially might benefit, and obviously not in a prostate cancer. That other study was in patients with ENT cancer. And I didn't say it was ready for prime time treatment. I just said it might be interesting to look at in future studies.
but what is your perspective on that difference that you see, in terms of, you look up on the website and you look at outcomes of prostate cancer and they're wonderful, but the actuality is that their outcomes are not all that great. That dichotomy is bothersome to me at a minimum. So, and I think that the reason why there's such a dichotomy is because of cardiovascular disease.
Yeah. Hi, I'm Sarah Faithful. I'm actually a prostate cancer nurse specialist working with people with ADT, and a researcher in late effects and cardiovascular effects of ADT. And if you look at a lot of the European studies that have taken registry and observer data, a lot of the age groups in those studies are much older than what you're seeing. So, for example, my average patient would be 74 years of age. And if you look at this study, they're a lot younger. And what I do know is that we don't do cardiovascular risk assessment commonly as patients go into treatment. If they're frail or not particularly fit or older, they don't have surgery. So in the UK, 50% of patients will go and have radiotherapy and ADT. The cardiovascular effects occur within the first year. So what happens is that their lipid profiles change within 3 weeks of starting ADT. So if they've already got cardiovascular risk effects, so for example, they may have atheroma or particular problems, you find that it accelerates their heart disease and they will get angina and problems. So they're usually not referred into cardiac oncology or into cardiac rehab. We've been doing CPETs on patients to look at their METs and doing VO2s, and they are low across the board because their fitness is poor, partly because of muscle loss. So they lose extreme muscle in their large muscles in their legs, and also we've seen an increase in diabetes as well. So the impact of it is quite substantive. Not just in terms of cardiopulmonary, as Linda was saying, it is actually muscle, and then they do less because they're weak and fatigued and unable to do things. There are quite a few studies in prostate cancer looking at high intensity exercise in this area to improve muscle function, but also to improve immune system responses. But a lot of the new drugs have exactly the same impact in terms of cardiovascular impact that we see in clinic. So it's, I think, some sort of recommendations about how to change it and when you need to put it in place is really critical, because these people aren't going to be doing a high level exercise straight off. You know, often climbing stairs is quite difficult for some of these older guys.
Yeah, I think your comments are very well taken, and also I think the comment that both you and Dan made about who is the patient that you're talking about, right? Is it a 45-year-old man who has early prostate cancer versus somebody who's 75, and where their level of fitness is and where their cardiovascular risk factor score is going to be very different in what you might do for those folks, both to improve cardiorespiratory fitness, but also to decrease the cardiac death rate, Dan, to your point. And I think that, as you both brought up, maybe also, and I should have put this in, was addressing cardiovascular risk factors more aggressively in these patients who are going to be at higher risk of cardiovascular death.
Well, the other interesting thing from this paper that you reviewed is the rate of aspirin and statin was pretty high. I was pretty impressed by that. Their population, 65% in both groups were on aspirin and a statin. I mean, that's pretty impressive, because I would say your average prostate cancer patient that I see never are on aspirin and a statin. And, that's probably the main thing that I do when I see them, is just, do the usual cardiovascular protective strategies. But yeah, I mean, so it's interesting that they only saw a difference after a longer period of time of ADT. Partly maybe it's because they were overall doing a better job about standard cardiovascular protection. So I don't know if that's true or not, but
I do wonder if they've selected patients because they've all gone for exercise testing. They may not be the normal population. Our average number of people on statins and aspirin coming through prostate cancer is less than 3%. So I wonder if these people already were identified as being at higher risk, and hence the high level of cardiac medication.
Yeah, I mean, that's a super good point. I mean, I think that probably has something to do with that. I mean, because like I said, my general feel, without reporting on it in any disciplined way, is that, less than 5% of patients are actually on aspirin and statin. So it would be similar to what you're describing.
And to Van's point, original point, if you remember, we had discussed the article about prostate cancer in advanced prostate cancer in patients with pre-existing cardiovascular disease, and it's not only about ADT, but the type of ADT that the patient is receiving. Because in that paper, I think it was in the Journal of Urology in 2019, they found that the absolute risk reduction of cardiovascular events was higher in patients who receive an antagonist versus an agonist. So taking into account the type of ADT when doing this risk assessment, I think it's important too. And in this particular paper, I never saw if they identified or described the type of ADT that the patients received. And on that other paper from 2019, what's interesting, and in contrast to this paper, is that they found that the majority of the cardiovascular events occurred between 6 and 12 months. And in this paper, they're exercising patients like 4 or 5 years after their cancer diagnosis, and which is kind of interesting.
Yeah, and I wanted to give a shout out. I think Dr. Badian is also on this webinar. He's got a trial of patients, not with prostate cancer, but with other cancers where patients are getting radiation therapy to the left chest and looking at cardiac rehab in those patients. And so I think, that's a very important area. And in doing cardiac rehab, we're putting out several abstracts now to the ACC, looking at all the different benefits of, cardiac rehab. And I think also when we talk about cardiac rehab and exercise training, when you're giving recommendations to your patients of what to do, we're telling people to walk and things like that, which are aerobic, which is fine. But I think we also need to focus on, targeted muscle mass building, even light weights for patients to maintain their muscle mass as well, and try to mitigate against the cachexia.
Yeah, Dr. Peterson, thank you. I agree with the muscle mass building, and that's something that whenever we treat patients with prostate cancer, we always try to advise them, especially when they're receiving androgen deprivation therapy, to make sure they're doing some weightlifting to try to maintain their muscle mass, because they always report to us that it's very noticeable that they are losing muscle mass and feeling weaker. I think that one also interesting weakness of this retrospective study is that they're dividing patients into essentially two categories, short-term and long-term androgen deprivation, but there's really essentially three categories, and I wish they had kind of separated it out, because we do put patients with high-risk prostate cancer without metastatic disease on 2 to 3 years of androgen deprivation therapy. But then there's another group of patients that get on indefinite androgen deprivation therapy, and those patients with metastatic disease. And it's unclear, they kind of group those two groups of patients together, but there was likely in that group of patients that have more than 6 months of androgen deprivation therapy, patients that have had 2 years of androgen deprivation therapy many years ago and have not been on it now for many, many years. And then a different group of patients that are continuing to be on androgen deprivation therapy when they had their exercise treadmill test. And those two groups of patients are probably quite different. One, their cancer burden is very different, and that might, considerably affect their exercise treadmill test. And the current presence of androgen deprivation therapy likely affects the exercise treadmill test as well. So I think that would be a really interesting thing. I wish they had kind of teased that out, because it may be that, current androgen deprivation therapy or indefinite androgen deprivation therapy is really the issue, rather than, long-term in the past, and patients have had a chance now to recover from it. And it's kind of interesting to see if we could kind of tease that out in a future study. So.
Well, and then to all of your points, I mean, the other thing would be, they probably can't do it because of the size of the study and follow-up, but, I don't know if there would have been a difference in cardiovascular outcome between those patients that were on statin and aspirin versus those that weren't. So, maybe it was, or it could be the exercise tendency that made a difference, but it also could have been, the combination of those medicines that would have made a difference. And, so I think it's great that they did this study, but yeah, I mean, there's still lots of questions out there.
The other thing to remember is that with metastatic prostate cancer patients is that they'd now be treated with docetaxel, which is also cardiac toxic. So additional chemotherapy is an additional sort of threat in terms of cardiovascular events. So I think historical studies don't necessarily easily translate now into modern prostate cancer treatment because of the new agents that are available.
Yeah, I think that's an excellent point. The ground is always changing under your feet while you're doing the studies, right? And just leaves more questions that need to be investigated. I will throw out also, and I kind of alluded to this earlier about the muscle power issue, is that there are studies both in normals and in patients with cancer and in patients with heart disease, that muscle power is an important predictor of survival. And in one study, it was actually even a greater predictor than VO2 max. That was only one study, but it was a large number of patients. And the fact that it's an important predictor of outcomes even in normal subjects, when they looked at Swedish Army recruits, I thought was just very telling. And it's something that as cardiologists, because we order VO2s, we order exercise treadmills all the time. We don't order, Biodex testing of large muscle group power or strength. And I think for that reason, it doesn't get as much focus on as important treatment target as well.
Yeah, very good.
Yeah, in our clinics, we do the step test plus sit to stand and grip strength as part of the pre-workup. And they're very simple, cheap techniques to use at a base level.
Yeah, totally agree.
Okay, fantastic, Linda. We really appreciate all your expertise and review and carefully done slides. I really think this was really tremendous. So we appreciate your engagement, and we look forward to learning more about this topic. And I also am very happy to get started on the rehab protocol that you referred to earlier.
That sounds great. Yeah. Well, thank you all for inviting me to the opportunity, and for, I learned a lot also, having to research. So thank you.
Yeah, I need to get the slide about Gleason score, right? That I was like, wow, that's pretty cool. That's a good slide. So
Google Images.
yeah, that's right.
I have a question.
Yeah, Avi, I saw you had your hand up.
Thank you. Great presentation. This is Avi from Case Western. I had a question. When people smoke, when they stop smoking for 10 years or 15 years, considered not a cardiovascular risk factor. So, is there a time for ADT? Like, because some of these patients were historical ADT users, some of them even more than 5 years ago. So, could you consider them to be an ADT user 5 years afterwards?
For the purposes of this study,
in general, like, this is a prostate cancer oncologist could probably also throw some light, because it seems like after a few years, it wouldn't be considered a risk factor anymore.
I'll let the oncologist answer that one.
Yeah, I don't know if Shahed or Sarah have some comment to that. I wouldn't know.
Can you repeat the question?
So the question is, does ADT remain a risk factor for people's lifetimes, or in context to this study, some of the ADT users were more than 2, some were more than 5 years ago they used ADT. Does it still count as a risk factor? Could you count them in that group?
ADT stays in your body for at least 18 months. So if you do fat biopsies of patients, you can still find the drug, and their testosterone doesn't go back up to normal levels, and sometimes never goes back up to normal levels, depending on the length of ADT they've had. So it remains in your system quite a long time. The question about whether it still causes risk factors is an interesting one. There have been some studies where they've taken people off ADT and then put them back on again to try and improve muscle mass, and the person's cardiovascular risk factors increase again. So it's a complicated question on whether it continues to be a cardiovascular risk factor.
Yeah, I agree. It's a very complicated question, and we don't really have a straight answer for it yet. I think it's part of what made this study interesting is, which patients are really continuing to be on androgen deprivation therapy and which ones are not on it anymore. And is the fact that, is there a recovery period? Do you ever really recover? Does a patient ever really recover from having androgen deprivation therapy in the past and have the risk factors, cardiovascular risk factors, go back down to baseline. It's unclear. So
this is Joe. I agree. I think that it sets off a process and a lifestyle that changes, and that the reality is that most of the people that I see who have completed ADT continue to have metabolic syndrome traits, and more often than not, their blood pressure is higher than it was before they were treated, or they didn't know what it was before they were treated. So I think that it proposes a lifelong vigilance and increased risk that we have to just take care of.
And one follow-up question, and thank you everyone. This was a great insight into this. And the other observation again to the prostate cancer physicians is, nowadays there's a discussion between the type of ADT, like GnRH agonist versus antagonist. Is there an observation about worse cardiovascular or cardiorespiratory fitness with one group versus other?
Well, I think the Prosper study that I referred to that was published in the New England Journal earlier this year was looking at, newer anti-androgen therapy. And it showed an improvement in overall survival, but a worsening of their cardiovascular status. So I think that, perhaps if you're treating the testosterone-based abnormalities better, then, from a prostate cancer point of view, that's a good thing. But I think it has impact on the cardiovascular status for sure. So the more intense you target that, the more likely you're going to have negative cardiovascular effects.
Awesome. Thank you. Thank you, everyone.
Okay. Thank you all so much. This was really great. Thank you, Linda and Shahed and Sarah and all the others. Really appreciate your attention and questions and discussions. So I know we have, I'm pretty sure we have a case study next week, same time. So we look forward to seeing you virtually next week. So thank you all very much.
thank you.
Thank you, Linda. Bye.
Thank you. Bye.
Bye-bye.
Thank you. Everybody stay well. Thank you.